All right, everybody, thanks for joining us tonight. We've got a packed agenda, so we may go a little bit longer than an hour. Um, this is being recorded. We'd had multiple requests tonight for this information, so we're going to record this and put it, share it within WakeMed's wall. So if you miss anything, you'll be able to find a link and be able to share this with your colleagues if any of them could not join us tonight. Our agenda will be, we'll go over our current numbers. Chris will go over the dashboard and his analysis. I will go over kind of what some of our neighbors are seeing and hope to kind of give us a sense of where this surge ends. We'll go over the CDC recommendations around and how WakeMed implemented the quarantine and isolation changes. Go through a couple of clinical adjustments and discussions that we've had recently around COVID. Amanda will go in detail around outpatient therapeutics because we've been receiving a ton of questions around all the new oral medications that are available. Karen Chilton will give a children's update. Our enterprise leaders will give updates, as well as Chuck providing information around procedures in the OR. And then Chris will update around staffing. Chris, I'll turn it over to you around the dashboard.
Excellent. So those who've been paying attention to this dashboard have noticed the dramatic and sudden change since about the second week in December. When you pull this data down and really do analyses on positivity rates changing, we began to see Omicron in our community probably right around December 15th in a meaningful way, because that was the start of the inflection that led to sheer verticality of our positivity rate. Our 7-day moving average of test positivity is now 42.7%, and that has led to the highest census that we have ever seen. You see down here that the 7-day moving average of admissions is still at 37, but we've been admitting 45 people a day now for several days straight. That's likely where that's going to even out. Our current record census was set yesterday around 11 o'clock in the morning and now sits at 223. So that is about 20 patients over our Delta surge number. I do want to take just a moment to go into a few sub-tabs here and then break out for a minute and talk a little bit about the change we're seeing in our ability to predict hospitalized numbers. I get a lot of questions around how many of these folks are here for COVID versus with COVID. And you all know as well as I do that it sort of doesn't matter from an operations perspective. We have to treat everyone with the same PPE. Everyone still gets isolated the same way. And so whether you're here with appendicitis and happen to have COVID, we're going to be wearing all the things and doing all the stuff. Our best way to proxy that information right now is this row here, which is our ID now positivity rate. Yesterday, this was 19%. Day before it was 16. And then if I scroll down, you can see it bops around. The 7-day average there is right around 15%. And recall that the only reason we use ID now is for asymptomatic patients who are either here for a procedure or it's our universal screening for admissions test. So that suggests about 1 in 8 people out there in the universe here in Wake County and our catchment area are positive and don't know it. And so that's been about our best proxy for the percentage of folks who are here with COVID, but not necessarily for COVID. We get a lot of questions around what do the vaccine numbers look like. This week, for the first time in weeks, we have some vaccinated patients on ventilators. This will take just a moment to pop up, but that's 4 out of 16. Those are also 4 people in the ICU out of 28, and we're still at about 80% of our total hospitalized numbers unvaccinated. I want to jump back for a second here. And so you can see the moving average of admissions has not gotten to a hook yet, but our 7-day moving average of positivity rate has. That's a really good sign. I want to drag you down to this graph here. If you look at this compared to this, This is 7-day average positivity rate. These are number of hospitalized people. Typically, this will top out, this was last year, right, about a week before this tops out. So this was the peak of our Delta surge there, August 26th. And then peak here, this was starting to peak about a week before that. From my perspective, unequivocally, we're seeing a clear hook here where we're sitting now around 42, 43% for a couple of days. I'm hoping that trend stays because that would suggest that we're seeing the first peak that we're going to have to see in order for this wave to sort of progress through, right? Typically, case count peaks, about a week later, hospitalizations peak, about a week after that, ICU peaks, and about a week after that, deaths will peak in a community. And this would suggest that we're starting to get to a case count peak, and we should level around perhaps 40 to 45 admissions per day and reach a level-ish hospital census for some period of time before that begins to break. I will jump off of the dashboard and back into the slide deck, David, because I did want to talk for a quick moment about modeling and why we have not been able to be more specific with this is exactly how many people we expect to be positive in our hospital. Take a look at this data. If you're a stats geek, these are pulled from Jump. So the two graphs on the right are straight up linear regressions where the x-axis is either the 7-day moving average of admissions on the left or the 7-day moving average of lab positivity on the right, predicting hospitalization. And if you take a look at those graphs, like the one on the left, you can draw a pretty darn good straight line through those dots. And that's reflected by the linear regression below. An R-squared of 93.5% says that a straight up linear equation predicts 93% of the variance of all hospitalizations. You can see on the right that held true until you get that wonky curve going all the way out that I've circled in red, and that is Omicron. And that drops the predictive ability pretty substantially. And so if you tab through to the next one, breaking it down by wave, we had a darn good equation for wild type where we could tell you pretty darn predictively what the 7-day moving average of admissions equated to for our average daily census of COVID patients. And our positivity rate would project that out, relatively well in advance. If you take a look, though, during the Delta wave, what you'll see on this set of graphs is steeper slopes. Right, so on the last slide, you had to multiply the 7-day admissions by 5.5. During Delta, you multiplied that by 7. So steeper slope, sicker people. Ditto with the positivity rate. The positivity rate on wild type, you multiplied by 900. Under Delta, we had to multiply it by 1100. And again, those R-squareds are about as predictive as any kind of model will ever get you to be. Which brings us to Omicron. And under Omicron, the positivity rate is just broke. And you can see we can still get to an equation on 7-day moving average of admissions. It's multiplied now by 4, right? So that is down, much less steep linear relationship, much different slope. But the positivity rate is totally wonky. In fact, the best predictive equation is quadratic right now. The linear equation is low, but I want to draw you just for a quick second to the shape of that curve, and then David, flip back to Delta. If you pay really close attention to the way this curve looks, you can sort of see the quadratic on the way up and then the other round on the way down. So what I really think that means is we're going to see some version of that football shape once Omicron peaks and goes down. It's just that line is going to be much steeper than it is right now. So all that to say, we don't yet have a great predictive capacity for saying where this ends on hospitalizations. It looks like our best call right now is around 240 to 250, including PUIs, and that we're likely to begin feeling that cap of a number over the next 10 days, and then hopefully starting to peel it back. But all that to say, Omicron, in our experience, really is as different as we're hearing it is in South Africa and London and New York City and everywhere else. If we had this positivity rate with Delta, we would be in a truly catastrophic staffing level, and we'd be looking at 400 or 500 COVID patients, and thank God that's not what we're seeing right now. So that's our local experience. David, I'll hand it back to you to start going through some of the neighborly experiences.
Great. Thanks, Chris. So I'm not the math whiz that Chris is. But what I love to do is see those people in those places that are ahead of us. We know South Africa, for example, is where Omicron was first described. We know that the UK is a week or two ahead of us. And we know in our local neighborhood that New York State received Omicron about a week prior to us. So by following their trajectory of where we are, we can see if we can predict where we peak. As Chris mentioned, the temporal pattern of a surge is the cases are going to come first. A week after that, the hospitalizations will start to decrease. A week after that, the ICUs will start to decrease. And then after that, you'll see the deaths peak out. So here's South Africa. In the upper left-hand corner, you can see each wave of new cases, and you can see truly there that Omicron wave is beginning to decrease. You can see there that Omicron was also higher than previous waves. The next chart over, the hospital admissions, you can see that their admissions were not as high, but you can see also the hospital admissions there are on the decrease as well. So new cases are way down, hospital admissions are down, and new deaths are continuing to trend up. So they are in that area where their admissions are down, but their deaths are not peaked yet. The UK is also ahead of us. The UK is in red here, and we are in the blue. And you can see the UK is just starting to do that hook that Chris described, where the case numbers are starting to go down. In the UK, the hospital admissions yet have not peaked. You can see that they're continuing to trend up as we are here in the United States. And the new deaths in the UK are continuing to trend up. And really here in the United States, we've not started to see an Omicron trend up in deaths yet. When we look more local to us here on the East Coast, you can see that New York State, the hospitalizations are continuing to trend up, and you can see the ICUs are starting to trend up. So we have not seen that deflection downward yet that we would like to see, suggesting that this surge is over. And once again, we would expect New York State, the hospitalizations, the ICUs to start trending down there before ours would start to trend down. So where I see things is South Africa is declining in all aspects. We know they're way ahead of us. UK is a couple of weeks ahead of us, and they may be starting to dip in their number of cases, so they may be starting their decline. New York State has not yet had a decline in their number of patients in the hospital or the ICUs. We should see that before we start seeing ours. And it's a reasonable, we will start to see our cases to decline before our admissions and our ICUs and so on and so forth. So I don't think that we are at our peak. I don't think that we're at our top yet, which is similar to what Chris is seeing. Some light starting to be seen on the horizon, but not there yet. Next, I'm going to go over the quarantine and isolation guideline changes. So this document is available on the internet. And basically what we've done here is tried to simplify exactly what an exposure is, what a vaccinated employee is, and describe how to do testing and return to work. Probably the most important thing on this page is our employee support center. So if you have questions, if you've been exposed, if you have questions because you're infected, that is the number to call. You can also email the COVID return to work at wakemed.org to try to figure out your return to work process. You do not have to navigate this alone. Our employee support team is here to help you. Also point out, I've had a lot of questions about what is fully vaccinated at WakeMed. At WakeMed, we are going by the CDC definition, and the CDC definition at this time does not require a booster. Certainly, we know booster is important to keeping people safer, but at this time, the CDC does not require a booster to be fully vaccinated. So when you're talking about returning to work, fully vaccinated is just having those 2 doses or being 2 weeks past your single dose of a J&J. Essentially, what this new policy did and the CDC recommendations allowed us to do is if you are without symptoms or mild to moderate symptoms that are getting better, you may return on day 6 if you're fever-free and improving. This was big request because we had a lot of people who were either had an asymptomatic infection, so they were traveling and wanted to self-test, or they had an exposure and they tested, but they felt fine and they really wanted to come back to the work. And doctors and other providers were like, I feel great. Why can't I come back? Why do I have to wait to day 10? This allows you, if you're feeling better, to return 6. You do not have to, on day 6, you do not have to get a repeat test. Just touch base with occupational health and you'll be able to return. It also has liberalized out the exposure when you'll be able to return your exposure. Essentially, if you feel better, you'll just continue to work, no quarantine required. If you start developing symptoms, then it certainly makes sense to get test. And throughout all of these, if you return early, if you've had an exposed, please, please, please be compliant with PPE, socially distance, don't eat around your colleagues. We know that even these requirements have been liberalized, there's still some small risk. So wear that mask when you come back or if you've been exposed. Some clinical adjustments. This is probably the one I've received the most emails about. The American Heart Association, that are famous for their CPR guidelines, released some recommendations about how we would resuscitate somebody with COVID. A large part of that was basically going in and starting CPR and resuscitation, regardless of what your protection was. And then basically when someone came in with adequate PPE, they would relieve you. As you might expect, this had a lot of people worried. So what we did was we brought in a multidisciplinary team, including our legal team, including our policy team, including our Code Blue team, emergency medicine, critical care, all the Code Blue members. And basically, we looked over everything around these new recommendations and our existing policy. Essentially, the American Heart Association provides recommendations, not regulations. So there's nothing in this that basically says we have to follow what the AHA recommends. By going over our existing policy, we realized that our existing policy accomplished what the AHA was trying to accomplish, which is basically that resuscitation starts very quickly. Basically, the way we've done this, when Amanda first helped CRT develop this policy, was basically Code Blue members are going to have PPE on them at all times to be able to resuscitate a patient. So they're walking around with backpacks, they're walking around with N95s in their pockets. And no time should there be a time where people have to jump in and do resuscitation without having adequate PPE. Before people go into a coding room, there's somebody outside the room basically handing out PPE to make sure that people can come in. So basically, this multidisciplinary team looked at these new HA recommendations and said, we are resuscitating people as fast as possible already. And our existing policies are very, very good about making sure that we protect our staff to the maximum amount. So this multidisciplinary team ultimately decided that we should continue to follow our existing policy. You can find this existing policy under the EPIC clinical links. And we continue to stress, please protect yourself. Take the time to put on those PPE. Take the time to put on your N95 and your goggles before you go into a room and resuscitate a patient. But these recommendations by the AHA does not change anything that we are going to do at this time. The second change that you likely heard this week is that across the hospital, everywhere from in operations centers, from the providers to the visitors, we're trying to get away from cloth masks in the hospital. The reason this is that medical grade masking over a cloth mask basically decreases exposure 50 to 100% over cloth masking, depending on the scenario. And with how infectious and how contagious Omicron is, CRT and our ID colleagues and our infection prevention colleagues thought this was very, very important to protect our staff and to protect our visitors, considering how infectious Omicron is. Cloth mask can be worn over your procedure mask if you think it looks better. The procedure mask can be WakeMed issued, can be brought from home. If you don't typically wear an N95, you can bring in a KN95 or an N95 if that's what you feel best in. Certainly, if you're going to be doing aerosolizing generating procedures or being around true COVID patients, then you need to be fit tested. So you need to wear a WakeMed issued respirator. But if you're not typically around COVID patients, you can bring in a KN95 or an N95 if you feel better. Visitors can wear KN95s or N95s if they wish. You can, if you're working in your office and you got the door closed, you can remove your mask. But otherwise, it really need to be dependent and compliant with wearing respiratory protection. If you, for whatever reason, do not have a medical mask, wear your cloth mask in until you can grab a medical mask and then switch over to that medical mask. We know that we've had a large amount of our staff out with Omicron. This is one measure that we and many other hospitals in the state and the country are using to protect our staff. I will turn it over to Amanda to talk about some therapeutics.
Thank you. So just in relation to COVID vaccine, again, the CDC and ACIP had a few updates. Boosters are now available 5 months after your mRNA primary series or 2 months after Janssen. Boosters for age 12 to 17 are available. This chart here helps demonstrate that they do allow mixing and matching. So Pfizer, Moderna, or Janssen could be your booster. The FDA and CDC jointly made recommendations that mRNA COVID-19 vaccines are preferred over the Janssen COVID-19 vaccine if you're 18 years and older, and Pfizer, again, is only available for 12 to 17. Thank you for all of the primary cares, high-risk OB, pediatric primary care. They are all establishing themselves as CVMS locations and have for some time and have been administering in their practices. Dr. Monroe, your pediatric primary care here in Raleigh is crushing it with 774 doses, but a lot of other practices are coming online and administering in the outpatient setting. So thank you for all of that effort. We also have our Raleigh, Cary, North Garner, and Briar Creek campuses and health plexes that are continuing to administer. Our WakeMed CVMS profile has over 143,816 doses on it as of today. So thank you for everyone that has helped with that effort. COVID vaccine appointments, WakeMed MyChart still has COVID-19 vaccine as an option. They are no longer in Andrews, however, it is in Raleigh Medical Park. That space is small, and we're currently scheduling appointments out into February currently. As a result, the team will have a booster blitz in Andrews planned for Saturday, January 22nd. So that will be available for scheduling shortly. You can also always make an appointment with occupational health. If you're an established patient in a WakeMed primary care, you can also obtain your vaccine there. And please also check out all of the multiple external locations. Wake County Health Department has several appointments available. All of these are now appointment only, though. It's very hard to walk into a place right now and get a booster. All right, outpatient COVID therapeutic options. This is just a quick review of our current options for monoclonal antibodies. We have switched from bamlanivimab, etesevimab, and casirivimab, imdivimab to sotrovimab. We have had this product for around 2 weeks now in very short supply. The number needed to treat is 21.7. Again, it's a single infusion EUA. It has to be started within 10 days of symptom onset. This is just to compare really the number needed to treat for the oral agents. So nirmatrelvir and ritonavir, number needed to treat is down to 18. That's going to be Paxlovid. And molnupiravir, number needed to treat is around 33.8. There are also there's an outpatient trial that looked at remdesivir, 21.7 there. There's
number needed to treat to prevent hospitalization.
Yes, correct.
Got it.
the issues here specifically, each product itself has its own complex issue for administration. Sotrovimab requires IV infusion. Paxlovid has a lot of drug-drug interactions we'll talk about shortly. Molnupiravir is the lowest efficacy, and remdesivir, it's not feasible quite yet in the outpatient setting. We're investigating that. It's also would require administration via IV for 3 days, so that would be someone coming in 3 days in a row to get an IV medication. And on top of all of that, supply is extremely limited. Monoclonal antibodies, we're receiving about 20 to 50 doses weekly of sotrovimab. Current supply on hand is 76. We are administering those Monday through Friday. We're only administering 12 doses per day in our Heart Center infusion unit on the Raleigh campus. You may recall previously we had about 4 different monoclonal antibody locations. Those have all been shut down due to the change in supply, and we are only administering out of the Raleigh campus right now. Paxlovid, we received 20 doses last week. Those have already been dispensed. Currently, our supply is 0, and we have not received any notification of any additional supply coming anytime soon. Molnupiravir, 80 courses were received and 4 dispensed. Current supply is 76 on hand. Again, just stressing that all COVID patients will not be able to receive therapy with this current supply. Please prioritize your highest risk patients and consent for appropriate treatment. Please do not guarantee treatment. Please continue to communicate with patients that supply is limited. We're just setting reasonable expectations here for these limited products.
Amanda, there was a question that came up. Someone had scheduled appointments. They were confirmed for this week. And then they had heard there was a, quote, risk we were going to run out of the monoclonal antibodies. Is that something people should be concerned if they have scheduled an appointment?
If they are scheduled for an appointment, they are confirmed we have supply on hand. We are not scheduling people into appointments without knowing that we have supply here in this hospital.
Excellent.
This is a complex chart that went out. This is thanks to the COVID therapeutics team and our pharmacy team, Abby Williamson, Shannon Holt, Jeanette, Allison Ivy, and many physicians here have been working on this WakeMed tiering system because products are so limited. This is evaluating all of those products individually and the different risk factors for patients. We're trying to prevent, again, mortality and severe illness hospital admissions. This chart actually is pretty similar to what the NIH proposed recently. As a risk stratification, it gets a little muddy and complicated because now we're actually taking in vaccination status in the tiering, which is emotionally difficult for many. We don't, of course, want to prevent those that have been vaccinated from receiving therapy, but if we do look at our vaccination status dashboard, those that are sickest are those that are unvaccinated, and we're trying to prevent that mortality. So the initial tier is primarily for the unvaccinated. Adults over age 65, BMI greater than 35, or pregnancy. Regardless of vaccination status, if you're immunocompromised or HIV with a CD4 count less than 50, that would also be tier 1. Those folks that are in tier 1 and some in tier 2 are currently being scheduled for MAB. That's kind of where our status changes. No one really in tier 3 or 4 are being scheduled for MAB at this point. We did receive several prescriptions for Paxlovid last week. All of those were filled for tier 1. Tier 2 now is, again, the vaccinated, again, adult age greater than 65 or BMI greater than 35, and pregnancy is also in tier 2 here. If we look at our supply of oral therapeutics, molnupiravir is probably going to be more in the tier 3 category as that supply continues to increase. Of all of our therapeutics, molnupiravir is the one that we are likely to receive more supply of and may receive an additional 160 doses later this week.
But Amanda, remind me, at present, we're operating under state limitation for tiers 1 and 2.
State recommendations, yes. For tiers 1 and 2, yes. So sotrovimab, again, no longer administering the other monoclonals. Supply is limited, only 12 infusions per day, Monday through Friday. Thank you. In order to refer a patient for that, it's an ambulatory referral, and the .bam consent was updated for sotrovimab. We didn't feel like changing the name. Everyone was used to .bam consent, so we're leaving it as .bam, but it populates sotrovimab for you. Paxlovid, just to review this, Paxlovid is several tablets, 150 milligram tablets, and one 100 milligram ritonavir tablet twice daily. It's dispensed from pharmacy and with blister packs. We do need to avoid use in end-stage renal disease or creatinine clearance less than 30. There's a dose reduction actually. If creatinine clearance is 30 to 59, pharmacy will actually pop out a few of those pills in that blister pack to make that happen. Please avoid in patients with severe hepatic impairment and multiple drug interactions. That box to the right there, pharmacy will be reviewing this when they fill these prescriptions. And when you try to order this, you may get an alert that says you cannot. Very common medications, statins, lovastatin, simvastatin, in particular, a lot of anti-epileptics are all on here that cannot be prescribed with Paxlovid. So lots of dose drug interactions to be aware of. In order to obtain this, you would e-prescribe to the WakeMed Raleigh outpatient pharmacy, and there's also a smart phrase, .paxlovid consent. This is currently, previously, this past week, I know we're at 0 now, but it was only available in the Raleigh outpatient pharmacy. If you tried to send a script to CVS or Walgreens, it would get denied. Many of those places do not have product. The DHHS website will update with where this product is going. I'm just not sure how real time that information is. Molnupiravir, again, 200 milligram tablets by mouth twice daily for 5 days. The big contraindication is not to use in pregnancy. Patients of reproductive potential should be counseled to use a reliable method of contraception correctly and consistently for the duration of molnupiravir, plus 4 days for females, the duration of molnupiravir, plus 3 months for males. Very strongly worded here in the EUA. Please be mindful and counsel patients regarding this. This is also in the dot phrase on the next slide as well.
That's 3 months.
3
That's
months.
not a typo.
That is not a typo. It is 3 months. Again, this can also be prescribed to the WakeMed outpatient pharmacy. If we are out of product and you're prescribing from WakeMed, you should get a BPA that fires that says we are out of product. But otherwise, please go ahead and prescribe, and molnupiravir consent is your phrase there. So lots to go over. You said I had 5 minutes. I'm sorry. I think I took a few more, but pharmacy is reviewing this weekly. They will be sending out more education regarding this process. And thank you.
Yeah, thank you. I mean, between monoclonals and these oral agents, our pharmacy team, our lab team has been basically doing nothing else but nonstop, but trying to keep this going. So thank you for all your work, Amanda. I'm going to see if I can get Karen off mute here. And Karen, feel free to share. I can't hear you yet.
Okay, got me now?
Yeah.
Perfect. Okay. So what I wanted to share with you here was just a little bit of state of the state in the pediatric world. So as many have heard, the Omicron surge has been treating children a little bit differently from the perspective of case positivity for the most part. So what you see in front of you is nationwide data that is through the 30th of December and obtained from health departments of 49 states, as well as New York City, DC, et cetera. So lots of good US nationwide data. And as of 12/30, children under the age of 18 were representing 17.4% of all cases And as you can see, total number of cases that's significantly higher than what's been experienced in the other surges. So the second graph, and again, this is not to terrify anyone or to take your breath away, but just for a dose of reality where we are. This graph is total COVID positive cases, or total positive tests, I should say, coming through the WakeMed labs. So this is patients who are in the emergency department, patients who are upstairs, patients who are at PM Pediatrics, patients whose labs are being sent from their pediatrician's office or elsewhere. Any tests in patients under the age of 18, they're coming through the WakeMed laboratories. And as you can see, our positivity has just absolutely soared in the past 2 weeks. So 2 weeks ago, we doubled the last week. And then from last week to this week, we nearly doubled another time. So the good news in this, contrary to what you might have read in the Washington Post right around Christmas or heard in some of the media in the past week or so, is that the number of admissions is really not following this trend line, similar to what we're seeing in the adult world. So in North Carolina, our total positivity is mirroring what I showed you from a national standpoint. And so as of the 3rd of January, which is the last full week that we have data completed on, 17% of total cases were under the age of 18. However, during that same time period, patients under the age of 18 accounted for only 3% of total hospital admissions across the state. And then here at WakeMed, just for a brief snapshot into what we have going on today, we have 8 total patients under the age of 18 who are admitted and COVID positive. And interestingly, 5 of them do have acute disease, but 3 of them are incidental findings. So I think Chris made the point earlier that, you know, from a resource perspective, use of PPE, where we're putting patients, et cetera, it really doesn't matter all that much whether the positive tests are incidental findings or true acute COVID positive disease when you come into the hospital. I think what it does matter for, especially in the children's world, is the optics of whether these various surges are more severe in children or not, which has been a lot of people's fear all along, right? Is that one of these variants is going to start to become much more severe in the younger age groups. So as of right now, I don't think we have any signals, despite the increased positivity in kids and the extremely high community prevalence. There's nothing indicating to us that this is dramatically more severe than the prior surges. We definitely do have more patients admitted who are COVID positive, but similarly to what we saw in the Delta surge, that certainly goes along with the increased community prevalence, but not to the extent of the positivity slope. I think I'll pause there for a second and just see if there's any questions about that before I talk just a tiny bit about vaccination in kids and monoclonal antibody. Let's see here. Doesn't look like we have any children specific questions in there at the moment. Okay. So vaccination wise, across North Carolina, we're currently sitting at 22% of eligible 5 to 11-year-olds who've had at least one dose. And then for the 12 to 17-year-old age group, that number is up to 47%. So very close to half of our 12 to 17-year-old population vaccinated across the state. Certainly, we want to continue to encourage that. And while vaccination is not obviously a surefire way to prevent yourself from becoming positive, we do still know that vaccination affects your likelihood to become severely ill. And in the case of the kiddos, the less that we are disseminating throughout the community and sharing, the better, especially when the positivity is so high. There should be lots of opportunities for kids to get vaccinated. The bulk of our community pediatricians' offices are providing vaccination. We did just hear today that one of the large practices has had to temporarily suspend their vaccination efforts because of their own staffing shortages and the acuity and volume that they're seeing in their offices. And they may not be the only one, but they're the only one we were aware of. But having said that, the county vaccination sites are now vaccinating all age groups, and there's lots of availability of those appointments when you go to their website. And in addition to that, many of the pharmacies, as Amanda mentioned, are also vaccinating, certainly down to the 12-year-olds and some even the younger, the kiddos. So please encourage folks to get vaccinated, and it should not be an issue to find availability of vaccine. And then the last thing that I will mention is monoclonal antibody. There was somewhat of a flurry right before the holidays over the EUA for BAMET in younger kids. And in fact, the EUA authorized use of the combination the whole way down to infancy. Our therapeutics group here at WakeMed got together and looked at the data that was available, as well as explored some experiences and practices that were going on both regionally and around the country. And the conclusion we came to at the time was that if we were going to provide monoclonal antibody to those younger kids less than age 12 under the guise of this new EUA, we would do it in a more narrow population with high risk factors, and not plan to give it willy-nilly, so to speak. And the main reason for that is that there's very, very, very little data for the younger age groups. And in fact, there were no children who were included in the data set that were younger than age 2. So we were really uncomfortable blanket saying that that we would be willing to give BAMET to the youngest kids, especially given that we are not seeing a significantly increased propensity for severe disease. Right around the time we had those conversations, then we learned that number one, BAMET was not found to be effective against Omicron, and number two, we were essentially going to be out of it anyway. So at this point in time, we do not have monoclonal antibody availability for anyone less than the age of 12. And Amanda showed you earlier where that 12 to 17-year-old age group falls into our tiers for eligibility based on availability and risk factors. I do see in the chat, I think Carrie is asking, are the COVID positive pediatric inpatients who seem to be truly ill with COVID vaccinated? So I would say that the vast majority of them are not. The kiddos who we have seen with the most significant illness have, by and large, with the exception of potentially one that I'm thinking of, not been vaccinated. What we have seen is when we have seen cases of MIS-C, we have unfortunately seen that occurring in both vaccinated and unvaccinated kiddos. All right, and David, I think I'll stop there. And then if people put other questions in the chat, we can circle back.
Thanks, Karen. Greatly appreciate it. And as you mentioned, if you have further questions, first leave them in the chat. We'll start going through our enterprises. We'll start with Dr. Bash, who I believe can't be with us. So I think Chris has an update.
That's right. We asked each of our enterprise CMOs to just give a quick touch base. You all are practicing in our enterprises, but wanted you to hear from them kind of where things are. And then Dr. Har will also give a quick update more broadly on our procedural platform. So Dr. Bash was in a 6 o'clock meeting, but she wanted, first of all, her thanks expressed to all of you for working so well together on trying to manage surgical platform issues. Obviously, the inpatient surgeries or surgeries that require patients to go to an inpatient bed post-op are the most challenged right now, whereas outpatient procedures that are purely outpatient are much less challenged. The emergency department at North has seen records across WakeMed the week after New Year's. For 5 out of 10 days, we set new records. One day we saw nearly 1,200 emergency department patients across the WakeMed EDs, and North has been running at times 150% of baseline volumes. The entire 4th floor at the North Hospital is now designated for COVID, and it's extended onto the 3rd floor. They are facing the same sort of challenges with staffing as all are, but again, really express their gratitude for the team at North and providers who are practicing there for pulling together and the work that's being done. From there, let's pass it off to Dr. Trzynski for a quick hit on the Carey enterprise.
Good evening, everybody. Thanks for joining us. I would echo Chris's and Karen's comments regarding all the great work that people are doing. Just a couple quick hits on Carey campus. We are right around 50 COVID patients right now. Our ICU has been full for the last week to 10 days. A little over of our 16 beds. I think we have 8 or 9 that are COVID positive right now, and 9 patients that are vented. Our 3 West unit has about a little over 80% of our patients up there are COVID positive, and 2 West has 8 patients as well. Our ED has been seeing about, actually, I'll go a little bit into the EDs in general in a minute. Our ORs have been doing okay as far as flow. I'll leave it to Chuck to talk about some of the procedural things, but in general, between staffing and our surgeons having illness and being out in quarantine or isolation, our admission numbers are about where we were at Delta. We've been flowing the building actually fairly well. While we're seeing about the same number of patients who did at the peak of Delta, we've been able to move the ED fairly well. We're seeing the same staffing challenges that everybody else is, although I think we may be in a little bit better shape than some. But so far, we've been able to handle the volumes that we've been needed to see. On the ED side, since going into the Christmas holidays, we were right around 100% of our volume that we were seeing in 2019. And since that time, we've been about 135 to 140%. It's been distributed a little bit oddly, though. Raleigh and Cary are pretty much like what it'd be in a very rough flu season, but we've seen huge number increases at North, at Garner, and at Briar Creek, which has certainly made things a little bit more difficult. The interesting thing, and this kind of backs up all the data that Chris showed you earlier, while we're seeing large volumes of patients, our number of patients that were being admitted is actually fairly low proportionally. And because the building's still been flowing pretty well, we've been able to handle that volume fairly well. All the campuses are looking at, and some are using some spaces that are non-traditional, but so far we've been able to keep up with volumes fairly well. I'm happy to take any questions, but that's for Carey, and the EDs are.
Thanks, Doug. I'll turn it over to Dr. Har for a Raleigh update.
Yeah, so the big news at Raleigh is that the amount of cooperation between Raleigh and North and Cary has been exemplary during this time. And I'll give you an example. Last week, Garner was slammed full. We usually take admissions from Garner. Cary said we have some availability with volume, and we've moved it around. So the ability of WakeMed Health and Hospitals to work as a system has really been enhanced. And between North and Cary and Raleigh, we work very closely every day to get patients out of the emergency department and onto a floor as quickly as they can. We have been fortunate in that with our staffing, we have kept up with most of our nursing volume and with in our procedural areas with travelers on a one-to-one basis. We had some crimp over the holidays because a lot of those contracts were out over the holidays, but people are coming back now. Obviously, that creates its own challenges, but what we're finding is they are highly qualified individuals who are coming to us as travelers. They just don't know where everything is here, and they're not as efficient because of that lack of knowledge. We saw some decrease in procedural volumes last week, partly because providers were getting COVID, partly because patients were contracting COVID or coming in with symptoms. So we saw some natural fall off in procedural volumes, both in the cath lab and in the operating rooms, just from natural attrition last week. There have been some really creative things that have happened, and I have to call out the cath lab and the neurointerventional program, in that obviously they don't want to take people to the cath lab without knowing what their COVID test is, but we've started prepping people in the ED, doing all the preparation short of doing the imaging, so that we cut down the time for STEMIs, we cut down the time for neurointervention for strokes, and that this shows the ongoing ingenuity and creativity of our providers and staff as we do this. The surgical task force has been standing by. We have been looking at whether or not to curtail volume really for a month now, ever since we started seeing the surge going up in December. Last week, the dyads met, and when I say the dyads, that's Doug and Tom Hughes and Karen Bash and Valerie and myself and Becky. We met and talked about it. At that time, we had the prescience of Chris saying this is going to continue going up and continue going up. We did not feel that we needed to tap the brakes at that time because of that. But obviously over the weekend, with the increase, we have made some changes. The surgery task force will be meeting tomorrow, and we'll see if other changes are made. One of the things on the Raleigh campus that we had instituted last week, which took effect today, was that all of our pediatric dental cases, which are truly elective, we had put off for a minimum of 2 weeks, and that freed up about 1 or 2 rooms in the operating room for us. Yesterday and today, we have looked at our volumes. If you saw from the numbers on the front, and this is on the Raleigh campus, our big challenge has been with our floor beds. So people who don't need ICU beds, but who do need floor beds, we have just really run into a wall. So normally we get anywhere from 12 to 20 hospitalizations a day out of the operating room, which doesn't seem like that much, but if you've got anywhere from 30 to 60 who are boarding in the emergency department, it's a whole lot. So we have asked our providers to convert as many cases as they can from admissions to those going home. For those who cannot be converted, we've asked them to look at the time sensitivity of that case, and if the case can be put off, we're asking that they reschedule them until after February the 1st. It is amazing what that response has been as soon as we put it out today, because I think everybody has seen what's going on in the hospital. Our ICUs run full, and as soon as we move somebody out, we're putting somebody back in, but they are not overbooked at this time. Certainly those cases, such as heart surgery cases, such as neurointerventions, such as cardiac cath labs, which are non-emergent, we are watching and monitoring those. And we'll continue to do so until this wave passes. We have had a number of staff out for illness, but that does not seem to be crescendoing as much as what the patient admissions are. And subject to questions, that's really all I have.
Thank you, Dr. Har. There was a question, and I think you're the best to answer it. There was a question, are we going to be adjusting our visitor policy anytime soon, considering the increase in numbers?
We have talked about that on several different occasions. At this point, we do not anticipate changing it. As you all know, there was a state law which came into effect, no patient left behind. And that, from a legislative standpoint, mandates that we have to allow a patient to have visitors. What that has mandated, what WakeMed has interpreted that mandate to mean, is we will allow up to 2 visitors a day for any patient. If they come to the screening desk and do not screen positive for anything. So they can't have symptoms, they can't have been exposed to COVID, they cannot have been told to quarantine, anything like that, and still come in. But as long as they meet all of those, then they are allowed to visit. And as long as the patient is in a private room, they may stay overnight with, one person may stay with the patient overnight. Um, So, so we do not anticipate that changing because of the legislative mandate for us.
Awesome. Thank you, Chuck. There were a couple of questions in the chat. Can patient receive COVID vaccine if they're positive and have mild symptoms? Even post-COVID, you can get the vaccine as long as you're outside the isolation period. So when patients are feeling better and their isolation is over and it's free for them to re-enter the world, they can get their first dose, second dose, booster, whatever they need.
So that could be as early as 6 days now.
Could be as early as 6 days now, right? There's a question about the flu showing up yet. So, Doug put it. We have seen a smattering of flu. Certainly, it's not a flu void year as we saw last year with essentially no flu. But the numbers have been kind of flat. So I think we'll just kind of see how influenza goes as we kind of move out through the year. Chris was mentioning something about our staffing.
Yeah, as we close out the evening, I just did want to spend a moment speaking to what has to be the thing I hear most when I walk the halls here in ambulatory spaces, you name it, and that is staffing volume. You all have heard from systems across the state sizable numbers of folks who are out on COVID protocols. For us, that's now around 2 to 3%, and we've returned 1% when the guidelines changed and evolved over the course of the last week. So we're hovering at a place that is tenable to continue operating at the global level, recognizing that at the hyper-local level, that even missing 2 or 3 people on a 5-person team can lead to challenges. And so there is not an hour of the day that goes by where our teams here in nursing, providers, EVS, and so on are not working to ensure that we have the staff and support we need to serve our community. You note that we have a sizable number of vacancies, and as Chuck said, we are spending record amounts of dollars to bring in the traveler support needed to close each and every one of those vacancies as we recruit. Folks have also asked to ensure that we are at market competitiveness for like bedside nursing and surge techs, and I believe most are aware that there was a substantial market adjustment that went out end of 21, first week of 22 for both direct clinical care nurses and for surge techs to ensure that we are competitive with market. I know of at least 2 WakeMed nurses who had submitted their letter of resignation and then rescinded it after receiving that market update. We know that pay is absolutely a component of why people leave. And we also know that there's no way for us to compete with travel pay right now. I mean, if you're able to go make $10,000 a week to work as a travel ER nurse, that is an absolutely significant amount of money that I think would be extraordinarily challenging for any health system to compete with. So we are making adjustments that we need to, and we believe we can, to continue sustainably operating, to fill in all the gaps that we have, and to work through this surge as we progress into what hopefully will be a much nicer spring. As Chuck noted, we're looking out to that first week of February as a time where hopefully we will reach the crest of this wave and begin to start riding down the back end.
All right, I don't see any other questions in the chat. We're bumping up right up 1 minute post. So that's pretty tight for a whole lot of information. Appreciate everybody that joined us today, and certainly appreciate everybody that's helped us maintain the wonderful place that WakeMed is through this pandemic. If you have any questions that we didn't answer, always feel free to reach out to us through email. We're happy to help you anywhere from therapeutics to staffing to how the enterprises work, from OR to procedures. Just reach out to us. That's the reason we're here for you. Have a great evening. Thank you very much.